Good morning, everybody. Shh. If everybody can find their seats, we'll get started. Shh. Good morning. Welcome. I'm Dr. Mo Gelbart. I'm the Executive Director here at the Thel McMillan Center. Good morning to everybody. Thank you again for coming. Thank you for supporting this program for more than 15 years now and our treatment program for more than 26 years. So we appreciate everything that all of you do and the confidence you put in us. Want to thank also the Meadows, our partner in this this lecture series that we put on. So Cheryl will talk to you at our halftime break, but Cheryl, say hello. And now's probably a good time since I think it's mine, but turn your cell phones off. I can turn my cell phone off, but I don't know how to turn this crazy watch off, so that may go off. Anyway, so we're excited about today's lecture and excited about today's topic, opioid addiction and opioid and preventing overdose. And I'm very excited about our speaker, Dr. David Sack, who I'll introduce in a moment. You know, everybody here knows you've heard tons about it and tons on TV about an opiate epidemic in this country. And you know, as I was thinking about introducing this topic, I realized how proud I am really of the people we work with and partner with. You know, many of you here work with, in different capacities, with people with addiction, people with opiate problems, and you've got lots of choices in where you send them when you need extra help than what you're doing with them. But you know, it's really important that you're confident with the program you send people to. You know, there is an opiate epidemic, and unfortunately the flip side of that opiate epidemic is there's a rash of, I'll call them in quotes, treatment programs that come up that are, you know, less than scrupulous, if that's the correct term. You know, they have patient brokering and paying for patients and outrageous lab costs, and, you know, you read about it being raided by the FBI and so on. So it's really important that when you think about utilizing a program, that you use a program that's got validity and reliability and that's been around a long time. And as I was preparing this talk, I said, you know, I'm really proud not only of the work we do here for 26 years, but I look at the Meadows, you know, our partner in this, and that's another great program, been around for a long time, has a great reputation in the community. I think about our speaker coming from Elements and Promises Treatment Center, and I think, wow, another great organization and great program. So, you know, as I say, you know, marketing and social media lets people with less than quality places sound really good. So you really have to do your due diligence when you're thinking about where to, you know, either get help for someone that you're working with or help for someone that you care about. So as part of that opiate crisis, you know, several years ago, we recognized at Thel McMillan, we have an opiate track for about 2 years now. I wish Gary Cezina was here. He's our director of the opiate program. And, you know, somebody comes in with that problem, they have a particular track. We do a lot of work with medication-assisted treatment. So, you know, we're trying to stay on top of it, especially as an outpatient program. It's not necessarily that easy, but we've recognized the problem, and I think we've done a really good job of addressing that part. So, in addition to the programs that we have, and if you have any questions, we have information in the back about our adult and adolescent program. Colleen Capistrano, our outreach coordinator, is here in the back, and she can answer any questions in the middle of our break here. We do an awful lot of community work. Amongst the community work are these lecture series, Frontiers in Addiction. As I said, probably at least 15 years we've been doing this. I'm always amazed, proud, thrilled to talk about, you know, our speakers. We get the best speakers in the country. You know, today will be another example of that. We get people who are keynote speakers at major conferences, and they often come here as a service to this community. Sometimes, you know, we pay them a small honorarium. We have people coming from the East Coast who pay their own way and their own hotel rates just to come and speak here. So I'm really thrilled about that. So today we have a great speaker. Next month, our next speaker, which is November 21st, is Dr. Kevin McCauley. We have flyers in the back. He'll be speaking on the The Brain in Recovery, update on neuroscience of addiction. And then we have our 2018 lecture series planned out already. And next program we have, which is in November, we'll give you new flyers, and we've got, again, another slate of incredible speakers for 2018. So I hope you come. Hope you keep coming. We have, it's a great deal. Free breakfast, free CEUs, and the best speakers in town. So what could be wrong? By the way, every other month where we do not have this program, we have a smaller program in our center called South Bay Networking. Again, it's a little shorter, 1 CEU, and free breakfast as well. Our next speaker there is Dr. Watson, our program director. He's not here today, but that's Tuesday, October 24th, and he'll be talking about substance use disorders in senior citizens. Lastly, I want to tell you about a program that's starting on Monday. Some of you may have read it in the Daily Breeze on Sunday, but we have a parent chat program. It's actually just a parent chat drop-in. We're partnering with Thel McMillan Center, Beach Cities Health District, and South Bay Families Connected, and it's getting incredible anticipation. So there's little cards in the back, but it'll be basically a drop-in group for parents in the South Bay to discuss whatever their concerns are. It's led by a great therapist, myself, and will be, like I said, it's free. There's no RSVP, no registration. Just drop in as they want, and that's Mondays from 10 to 11 a.m. at Beach Cities Health District. So finally, a little housekeeping. As I say, shut off your cell phones if you can, if you would. Secondly, Dr. Sack, there'll be a break in our, when he takes it about halfway through, bathrooms are in the back, be a 10-minute break. CEUs, if you sign up for CEUs, you have to stay till the end, okay? You can't leave in the middle and get your CEUs. We are monitored for that, and we don't want to lose our privileges for being able to provide those CEUs. So let me introduce our speaker, which I've known for over 30 years, and I'm really thrilled that he's here. David Sack, MD. He's the Chief Medical Officer of Elements Behavioral Health. After receiving his medical degree from Rush Medical College, Dr. Sack completed an internship and residency in psychiatry at the UCLA Neuropsychiatric Institute. From there, he joined the clinical psychobiology branch of the National Institute of Mental Health, where he contributed to seminal research in seasonal depression and sleep deprivation therapy. Dr. Sack has held leadership positions in several privately funded clinical services and research organizations, including Aspen Education Group, Comprehensive Behavioral Health Management, and Comprehensive Neuroscience. Dr. Sack founded Element Behavioral Health in 2008 and currently serves as Chief Medical Officer. Elements is now the leading privately owned provider of addiction and mental health programs, offering innovative treatments for substance abuse, sexual addiction, trauma, eating disorders, and other mental health disorders. Dr. Sack is board certified in psychiatry, addiction psychiatry, geriatric psychiatry, and addiction medicine. So we're pleased and proud to have Dr. Sack speaking today. Welcome.
Well, my mother would have been so proud after that introduction. I really want to thank Mo Gelbert and the McMillan Center for inviting me to come and speak today. The issue of opiate overdoses is something that I live with every day. We have over 850 beds across 9 states and 13 campuses. And so this is something that I live in fear of and dread of, and have spent the better part of the last couple of years trying to find better ways to manage down that risk. So I'm going to be sharing that experience with all of you today. I also appreciate that everybody braved the traffic to get here this morning, so thank you. So I have no conflicts of interest. So what are our goals today? I think we want to come away understanding what client behaviors increase the risk of overdose. We want to be able to differentiate the clients with the highest risk, and then we have to understand that when we make treatment choices, that affects both the outcome and the overdose risk, and that it may not be necessarily in the same direction. And finally, I think we have to understand that this risk of overdose is greatest in the first year, and to look at how we can change both our treatments and our strategies to lower that risk of overdose. So, when I was writing this talk, I realized that, we use these words so commonly that we may have forgotten what they mean. So I wanted to just start for a second and explain what is meant by an overdose. The federal government does not classify deaths as overdoses. They classify them as accidental poisonings. But they're not just any kind of accidental poisoning. So it's an accidental poisoning that may or may not result in death, but where the health and safety and life of the individual is in jeopardy. It always involves some level of impaired consciousness and responsiveness. So when we talk about overdoses, we're talking about someone who's become comatose under the influence of the drug. There was a time where overdoses involved primarily heroin, and it was usually one drug. The most common scenario today with overdoses is a combination of drugs, but usually also still involves an opioid. Overdoses are not suicide attempts. So when we think of what is an overdose, we're not talking about people who tried to kill themselves and didn't get it right. We're talking about people who were using drugs carelessly or in excess and then wound up in a dangerous situation. And finally, for it to be an overdose, it needs to require medical assistance, that is 911, emergency room, friends trying to resuscitate them, or would likely have resulted in medical treatment if the individual had been found. It's not unusual for people to overdose and wake up 2 days later with catastrophic medical consequences, but they didn't actually receive care at the time of the overdose. Is that clear for everybody? Okay. So why do people die of overdoses? So the number one reason that people die as a result of an overdose is respiratory arrest. The drugs involved, particularly opioids, sedative hypnotics, and alcohol, all are potent suppressors of the respiratory center in the brainstem. And so when they overdose, they stop breathing. But there are other reasons that they die. Aspiration, that is a gag reflex that causes the person to vomit, can result in them aspirating that vomitus, and then they asphyxiate because the airway is blocked. Cardiac arrhythmia. There are times, particularly on stimulants and cocaine in very high doses, where the overdose is not the result of respiratory arrest per se, but of a cardiac arrhythmia triggered by the medicine. Circulatory collapse can occur, particularly from hypovolemia. And then, in cases where people have overdose and they're motorically inactive, in other words, that they're basically lying on a floor or a bed or a couch for 2 days, you get massive breakdown of the muscles in the body. And when that occurs, it literally chokes off the normal activity of the kidneys and causes kidney failure, a process called rhabdomyolysis. So a number of factors contribute to overdoses, and we're going to be revisiting these in different ways over the course of this talk. There's no question that IV drug injection is a very big risk factor. IV drug users are significantly more likely to overdose than oral drug users. Polysubstance abuse, and we're going to talk about why, adulterants, and finally, we're going to spend a lot of time towards the end talking about treatment effects and how they influence overdose risk. So why is IV drug addiction such a problem? Well, the big issue is that it has a rapid onset. So if you think about, how quickly a drug gets to the brain, if you take a pill, it has to be absorbed in the stomach. That can take 2 hours. It then has to reach the circulation. It then has to travel to the brain. It has to cross the blood-brain barrier. Well, if you shoot up a drug, it's directly into the bloodstream. You've cut out most of those middle steps, and so the effects are often felt within minutes. So rapid onset of action is one of the reasons why it contributes. But there is another factor, which is that it's very hard to take it back. That if you're getting high on a drug that works gradually, and you say, gee, a couple hours have gone by, I think I'd like to be a little bit more high than I am right now, you have some control over it. But when you're shooting up a drug, the effects are instantaneous, and there are no takebacks. So that's a really big factor. The other problem is that most of the drugs that are used intravenously have very short half-lives, meaning that they work in the body for a very short period of time. So what happens is that in order to keep your high going, you have to keep injecting. So the number of times that you use in the course of a 24-hour period can be very large. So intravenous users tend to use more often than people who are taking drugs orally because they're trying to keep their high going. Does that make sense to everybody? Yeah. Okay. And then there's treatment. You know, I think that in the 1980s, there was a form of absurdist humor that asked really silly questions. But one of the jokes was, what's the difference between a dog? And the answer was, its two left feet aren't the same. In addiction medicine, we tend to look for similarities and cohesion. We want things that can explain the behavior of addicts across multiple drug types. But one of the biggest challenges that this opiate epidemic has caused is we cannot treat opiates the same way we treat alcohol or stimulants. And so a big part of what we're going to examine today is why. What makes these things different? Why does our fundamental approach have to factor in to the much higher risk of overdose? But before we get there, I think we have to review some basic concepts of addiction or it won't make any sense. So what is tolerance? You know, if you think about it, if you use a drug repeatedly, you get less and less high. You know, the old expression, I get no kick from champagne. You know, if you use a drug repeatedly, there are changes in the brain that occur that tend to dampen and attenuate the effects of that drug. And that process is called tolerance. And what happens in tolerance is that brain receptor systems try to compensate for the presence of a drug. So if you think about alcohol, for example, the brain senses that you're more sedated because alcohol interferes with the effects of glutamate, which is a stimulant, and it augments the effects of GABA, which is an inhibitory neurotransmitter. And in our brain, we're constantly gauging the effects of these neurotransmitters and trying to adjust our arousal to a level that's appropriate. So when a drug is present, our brains try to compensate for it. So we try to override that drug signal. Now, if tolerance were complete, we would have no drug addiction. Because if you think about it, if our brains were capable of completely offsetting the effects of heroin, if the person kept shooting up, eventually they would get no benefit from it, and they'd say, well, this isn't fun, and they'd move on to something else. So one key concept about tolerance is that tolerance is never complete. So the person develops tolerance to some of the effects of the drug, but not all of the effects of the drug. The second problem with tolerance is that if you have a chemical system that is part of our body's core regulating system, that's part of our survival system, then you're going to have receptors in different parts of the brain. So you have opiate receptors that are involved in regulating respiration. You have opioid receptors that are involved in regulating pain and perception. You have opioid receptors that are involved in the regulation of mood and anxiety. So when you have tolerance in the brain, you do not get tolerance for all of the receptor systems at the same rate. So you can get a vast amount of tolerance to the euphoric effects of a drug and relatively less tolerance for the respiratory effects of a drug. So the same person needs to take more and more drug to feel the high, but their respiratory center can't tolerate that, and so then they overdose. So tolerance never occurs equally across all the different brain systems that are involved. In the case of opiates like heroin and OxyContin and Vicodin, they bind specifically to the mu opioid receptor in the brain. That is, almost all of the intoxicating effects of these drugs are mediated by a specific receptor system in the brain called the mu opioid receptor. And that when you have repeated exposure to opioids, and opioids is a relatively new word because what it includes is both drugs that are chemically similar to morphine and heroin, that is, that are opiates and are similar to the alkaloids that are derived from the opium plant, as well as drugs that may be chemically dissimilar, like tramadol, that stimulate the opioid receptor but are not chemically related to the opiate plant. Anyway, repeated exposures to opioids decreases the responsiveness of the mu opioid receptor. So it becomes less and less sensitive to the effects of that drug. So that's what tolerance is. So if that's what tolerance is, then what is withdrawal and what is detox? So, when a drug is discontinued abruptly, the neurons that are involved are in a dysregulated state, or allostasis. That means that they're expecting there to be this drug around because every day you get high, so every day we're compensating for it. And when that drug isn't there, we're overcompensated. We don't need all of the re-regulation that has occurred. Now, this re-regulation involves changes in brain receptors, it involves protein synthesis. It can't be reversed on a dime. It's not like you're going to fly across the left lane and make that turn. It takes days and weeks to fully reverse the effects of these drugs. And we're going to talk more about reversing the effects of tolerance. So what withdrawal is it's the response of the brain to the abrupt cessation of the drug that you've been taking. So you've developed tolerance, your brain has compensated, and when you stop, there's an insufficient amount of the endogenous opioids around to regulate that system properly. And in our bodies, there's sort of two different opioid systems. There's the beta endorphin system that's produced in the pituitary gland, and then there's the peptide system, the enkephalin system, that really acts more like a neurotransmitter, is produced in the brain in the same cells that produce serotonin. Anyway, over time, the withdrawal is reversed because our brains gradually get back to a homeostasis, and the tolerance is reversed as our brain receptors return toward normal. So what is detox? Why do we detox people, and what is it? So when we talk about detoxification, what we're doing is giving people medicines to cover over this period where they're in withdrawal, to help them through this period that it takes the brain to adjust and to reverse the tolerance. So that's what we're doing when we're detoxing people. So what is detox? So detox is a process where medications are administered to counteract withdrawal. So these medicines are often chemically similar to the drugs that the person is withdrawing from. So when someone is withdrawing from alcohol, we frequently use things like diazepam or Valium or chlordiazepoxide or Librium, which have similar effects in the brain to the alcohol, but are safer. So we're often using drugs that are in the same general category to mitigate and to regulate that reversal of the tolerance. And these drugs may directly replace the drug. So in the case of opiates, the drugs most frequently used to do withdrawal are things like methadone and buprenorphine, which directly replace the heroin, morphine, oxy, or they could be indirect effects of those drugs. So we also use drugs like clonidine, which affect the hyperarousal that occurs when you stop an opiate, but is not stimulating the opiate receptor itself. So, it turns out that we've been doing detox for a really long time. And in general, detox from opiates takes anywhere from about 3 to 7 days. Most people at our centers can be detoxed within about 5 days, even high-dose heroin users. So the initial treatment with detox is not something that's all-encompassing or vastly time-consuming, because our treatments have improved. If you were to go back 20 years, which is when I started, it was very difficult to detox heroin addicts. And the vast majority of them left against medical advice within the first 48 hours. They never got withdrawn. Today, we have over 90% success rate in detoxing people with opioid dependency. So the issue of detox has been largely improved, primarily due to one drug, buprenorphine, which is a really great medicine for managing detox. The problem is that detox by itself is not a treatment for addiction. And probably the best study that looked at this was a study done in Australia called the ATOS study. And it's really hard to do longitudinal studies of drug addicts, even in a place like Australia where you have a closed healthcare system and where everybody who's come for treatment. So they did a study where it was treatment as usual kind of study. So people were not randomly assigned to specific treatments, but because their system offered different treatments, they could reasonably look at what happened to people who went through one treatment versus another. So they had a group that went through detox only. They had a second group that went from detox onto methadone or buprenorphine, although in Australia it was mostly methadone. They had a third group that went to residential treatment. Now, residential treatment in Australia is more like long-term sober community in the United States. It's more like sober living for 6 months to a year. So although they call it residential treatment in the article, it's more like our sober living. So these were people who were detoxed and sent to sober living. And then they had a fourth group that was their control group. And their control group were heroin addicts living on the street who were not interested in treatment because they had a whole social services outreach system. And so they had a system for approaching active heroin addicts and trying to get them into treatment. And when they said no thanks, they basically offered them the opportunity to participate in this research study and to be paid like $10 to be interviewed every 6 months to see how they were doing. So that was the control group. So when you looked at the first year, and again, there are very few studies that have been done in the last 35 years that have looked at the benefits of residential treatment for opioid dependency in the United States. And part of this is because prior to the introduction of methadone in the 1960s, we had involuntary commitment for addictions. So someone who was alcoholic or addicted in most states could have been involuntarily detained and put in a mental hospital for treatment, whatever that was. And after about 10 years of that, all of the retrospective studies showed that it did no good, that people who were involuntarily held for treatment for methadone, for heroin addiction, derived zero benefit. It was no better than doing nothing. So in the United States, and there were a lot of abuses, as you might imagine, putting people in state hospitals involuntarily for long periods of time created a kind of gulag. And really, in the 1970s, in the interest of promoting rights, most of these laws were reversed. Interestingly, there are still a couple of states where you can involuntarily detain people to treat their addictions. Connecticut is one of them. And recently, Florida reenacted a statute to allow for people to be Baker Act, which is their involuntary hold, for extended periods to treat their addiction. So in the United States, we largely abandoned this notion that you could keep people in a sober environment and expect that they were going to get better. But the ATOS study was one of the few studies that systematically evaluated people going through extended residential/sober community treatment. And what was really interesting about the ATOS trial is that in the first year, the people who went through extended residential treatment had the same outcomes as the people who got methadone. And in the United States, there is a very deeply held belief that residential and abstinence-based treatments don't work for opioid dependency. In the medical community is a very strong belief, and we're going to revisit this. But in the ATOS trial, people who went through acute treatment and then had an extended residential experience at the end of the first year did as well as the people who went directly onto methadone. Now, the people who, this is about detox. I know it's been a little winding here, but so getting back to the issue of detox, how do you think the people who got detox alone did? Anyone? You're all professionals. Poorly. How poorly? Very poorly. That's right. Very, very poorly. So the people who got detox alone did no better than the heroin addicts who were living on the street, who were paid to be the controls. So I think this is really important. So we should never mistake detox as a treatment for addiction. Detox is a treatment to prevent the complications of withdrawal. It is not a treatment for dependency. Is that clear to everybody? Okay. So what we do in this field is really about what we do after detox or in lieu of detox. It's not about detox. A lot of the hubbub and agitation about getting people into treatment has to do with the fact that detoxing can be life-threatening. So we're trying to prevent these life-threatening complications. But detox by itself is not a treatment for dependency. The problem that we have with opioids is that detox actually increases the risk of overdose. And so why is that? Well, it turns out that when you detox people from heroin, because they did in the ATOS study have this detox condition, only 1 out of 7 people who was detoxed was continuously abstinent over a 12-month period. So 85% were using off and on throughout that period. And that's a problem. And we're going to go over why that's a problem. I know everybody here is thinking our programs do much better than that. It can't be us. So here's why it's a problem. It's a problem because when people relapse, they don't overdose a year later out here, they relapse over here. So within the first 2 months, because that's what we're talking about here, 42 days, you have most of your overdoses. So the reason that that occurs is because we have reversed their tolerance. If I am a regular daily opioid user, I have massive tolerance to those effects. And so even though my respiratory center is still vulnerable, it has developed a certain amount of tolerance. But when we stop those drugs and detox them, this is the consequence, that we make them much more vulnerable if they use. And how many are going to use? Let's see who is paying attention. How many are going to use in the first year? That's right, 1 out of 7. So 6 out of 7 are going to use. So this is not an incidental problem. We can't treat people hoping that we're going to get that 1 out of 7. We're going to talk about who the 1 out of 7 are versus who the 6 out of 7 are in a minute. So this raises an important question about addiction medicine in general. And that question is, what are we treating and why are we treating it? Because a lot of what we assume happens in the course of treatment is simply wrong. So I'm going to show you, so before we get to what happens with treatment, I think we have to realize that we work in a field where there's very little consensus about what addiction is. So that in order to understand the conflicts and the problems, we need to understand a little bit about how different parts of our community, our treatment community and recovering community see addiction. So if I were to ask all of you, what is addiction? So if I were to say, let me see if this is on. Can you still hear me okay? Okay, so it must be on. Let me turn the slide off for a second. So if I were to ask all of you, what is addiction? Just call out, what would you say? A disease of what? What kind of a disease? Brain disease. And were you saying brain disease also? Disorder of the brain. What else is addiction? Well, an inability to control impulses, okay. What else? There's always a lot more. Okay, so there's other things. What are those other things? When we think about a lot more, what are we thinking about? Self-soothing. So they're trying to medicate away a problem. Okay, what else?
Problem in the reward center of the brain?
Well, yeah, I think that's sort of tied to this, but yes, I would agree. That's certainly one theory of it. Anything else? Pleasure. Okay, so let's put the slides back up for a second. So, a disorder of the brain's reward system. This is clearly the view of the American Society of Addiction Medicine. They define addiction not in terms of drugs, but as a disorder of the brain's reward circuitry and related areas, and that could be caused by drugs, it could be caused by sex, it could be caused by gambling, but it's a disturbance in the brain's reward circuitry. So what does this have to do with recovery and the 12-step community? I mean, how does this relate to recovery? How does the 12-step community think about addiction? Are they worried about the brain's reward circuitry? Is this the primary focus of recovery? No. Yeah, so recovery thinks about it as a spiritual malady of self-centeredness. This is a spiritual malady that's caused by focusing too much on yourself. And a lot of the treatment is really about correcting this moral deficit and finding a way to see beyond the self. We heard about impulsivity, impulse control. A lot of genetic studies suggest that part of the risk of becoming addicted is a genetic predisposition toward impulsive behaviors, of which taking drugs or alcohol may be one of them, but there are other impulsive and dangerous behaviors, criminality, high-risk sports, and other things that seem to be inherited along with this risk toward impulsivity. Those of us who've worked in the public sector and have worked with communities that are underserved and who have limited access to opportunities tend to see addiction in terms of poor nurturance, abuse, and neglect. So this is the notion that early childhood abuse and neglect, whether that's physical, sexual, emotional, clearly can contribute to later onset of psychiatric disorders, including addiction. And finally, we heard this sort of self-soothing hypothesis, which is that addiction is an attempt to cope with intrapsychic distress, that people use drugs to self-medicate for psychiatric symptoms they can't control otherwise. Now, depending on how you think about what addiction is, it is going to govern what treatments you provide, because the kind of treatment you provide for a disorder of the brain's reward system is kind of different than the one that you'd provide to someone who's trying to cope with intrapsychic distress. So sometimes I take some solace in this cartoon, because there's so much lack of agreement in our field. But it may not matter. If you think about 12-step recovery, it's a behavioral system. Follow the path. So this is just a reminder that no matter what we believe, there may be things that work because they're behavioral and direct and make a difference. So I didn't think I'd ever be able to stop, but then my wife moved the glass away. So one of the challenges, though, in addiction is that the reason that people start taking drugs is probably a little bit different than why they continue to take drugs. And this is one of the reasons why we get so bollocksed up. So why do people start taking drugs? What's the number one reason that people? Social. That's one reason. Peer. They want to feel better. What else? Curiosity, pain. Traumatic events. Yeah, there's a very mental health group. Most people I knew in high school who took drugs wanted to get high. But all these are good answers. Don't get me wrong. I don't have any personal experience. So why do people start taking drugs? So intense pleasure is the number one motivator. I mean, when people think about getting high, they're looking for this intense rush that other people have described to them, and they want to know what all the cool kids are doing. What is this thing called getting high? We heard about, to feel better, to alleviate these negative affects. This might be the depressed kid who starts rolling, joints in the morning and is smoking all day long because they can't cope with their depression. We're not going to talk about it today, but enhancing performance is another reason that people take drugs. This could be steroids for sports, or it could be amphetamines for school performance, but you get the idea. And finally, curiosity. People want to know what other people are doing. And so if other people are having a good time, they want to have a good time. So if those are the reasons why people start taking drugs, how does this change when people become habitual or regular drug users, or what we might call addicts? How important are these various things? Yeah, so part of what happens is that it gets harder and harder to experience the same rush or intense pleasure because of tolerance. And so they find themselves chasing that high because getting that intense pleasure gets harder and harder over time. What else happens if you're a regular drug user? You have withdrawal, and that's correct. That compared to when you started, you now have another negative affect that you didn't have before, which is that if you don't use, you're in withdrawal. What else happens? Preoccupation. That's right. It's interesting. Those of us who are not addicted or who have not been addicted to drugs have a hard time understanding the preoccupation and the mental space that addiction takes up. But for the addict, craving and thinking about getting the drug, finding ways to use it, fantasizing about how you're going to use it and who you're going to use it with, consumes their entire day. That's what life is about. And craving really doesn't happen to you unless you're addicted. And you can have people who early on in their alcohol use have intense cravings, but they typically become addicted fairly soon after that. So craving is something that the people who are addiction prone and addicted experience that normals don't. So people keep taking drugs to alleviate negative affects, and those negative affects could be the ones that they started with, you know. But let's face it, if you use opiates enough, your life becomes a mess. Your job is in jeopardy, your partner is leaving you, your finances are a wreck, so that in addition to the problems that you started off with, now your entire life is in chaos. You now have two things that you didn't have before to contend with: cravings and withdrawals. So we heard about that. And then, you know, you have what's social reinforcement. I mean, if you think about it, if you're a heroin addict, who do you hang out with? Heroin addicts. So that part of what happens with drugs is that people who become addicted derive a lot of the benefit from being addicted from the social reinforcement. And part of that has to do with the fact that people who become addicted have impairments in their emotional relatedness. There's a condition called alexithymia, this inability to feel or to interpret how other people feel, that's very common in addicts and alcoholics. So they tend to be drawn to the kind of pseudo-intimate experience that occurs when you're getting high. Because if you get high with a friend and you're both getting a rush at the same time, you're feeling calm at the same time, you're getting sleepy at the same time, you may experience that as a relationship, even though it's really just a drug. So if that's why people continue to take drugs, then treatments can work by decreasing cravings. They could block the pleasure that the drug causes. They could decrease the abstinence syndrome, the withdrawal syndrome, or they could interfere with the social reinforcement. And we have treatments today that do one or more of these things. So before we talk about those, I just wanted to quickly review the brain's reward system. So what we have here is a simple schematic. The blue is the brain's dopamine system. And what you can see here is that the cell bodies that contain the dopamine in the reward system are in the ventral tegmental area. And then they synapse with the nucleus accumbens. The mic is off? Is that any better? Yes. Okay. I must have like a power saver. I apologize. Okay. So what we have here is that the cell bodies for the dopamine are in the ventral tegmental area. They go to the nucleus accumbens, which is sort of reward central. The nucleus accumbens measures the rewarding effects of an activity, a drug. So it's the salience of that experience that is gated by the nucleus accumbens. And then the projections go all over the brain. They go to the hippocampus for memory. They go to the medial prefrontal cortex for reward and mood, and into the limbic structures for mood and anxiety and memory processing. I use this slide just to remind you that in the brain, nothing exists in isolation. Every nerve is connected to at least 12 other nerves. And so this is just an example of how there's this close interaction between the serotonin system and the dopamine system that's involved in reward. So, you know, about 20 years ago, the dopamine hypothesis of addiction was proposed as a kind of overarching explanation of addiction. So what is the dopamine hypothesis? And, you know, is everyone here familiar with it already? Okay, so the notion of the dopamine hypothesis is that all drugs of abuse either directly or indirectly raise dopamine activity in the brain, and specifically in this mesolimbic dopamine system, or the cortico-mesolimbic dopamine system, the reward pathway. So the idea is that even the drugs that don't directly stimulate dopamine cause it to be increased in the nucleus accumbens. So if you're looking at alcohol, alcohol does not bind to the dopamine receptor. I mean, alcohol binds to just about everything else. It binds to glutamate, it binds to GABA, it binds to serotonin, but it does not directly influence dopamine. But what it does do is it causes enkephalin to be released in the median raphe nuclei, and then that stimulates the release of dopamine. The dopamine hypothesis is one of the few things in our field that was welcomed by both the medical community and the recovery community. It was welcomed by the medical community because it provided a pathway to where to start to look for treatments. It said, well, if everything is being driven through this reward system, then let's try to find treatments that affect the reward circuitry. Now, as you might imagine, the results have been mixed because reward's really important in why you choose to start using drugs, but is actually very unimportant, relatively speaking, for why people continue to use drugs. Nevertheless, it was a very big step in terms of understanding things. For the recovery community, it was a validation, I think, of a centrally held tenet that drugs are drugs, that all drugs are suspect, and if you're going to be abstinent, you want to be abstinent from all drugs. So that this hypothesis was a unifying concept that seemed to pull a lot of divergent communities within the addiction treatment space together. The problem is that it's overly simplistic, and it ignores the vast differences, both neurochemically and pharmacokinetically, of the various drugs that are being abused. So even though the rewarding effect of these drugs may be mediated through dopamine, there are lots of other things they do in the nervous system that we've been talking about in terms of tolerance and breathing and other things that have nothing to do with dopamine per se. And so if we think about this as a way to explain and to drive all of our treatments, we're going to miss the point. The other problem is that it turns out the dopamine hypothesis has not resulted in a single effective treatment. So although we believe that dopamine is really important in why drugs are experienced as rewarding, it may be a dead end when it comes to finding treatments. What is important is that chronic drug use injures the brain. And we don't have time to go through all of the ways in which it injures the brain, but I'm just going to sort of call attention to one of them. So one of the things that occurs is that if you have dopamine being released over and over again, you get sensitization in the dopamine parts of the brain. And those of you who've worked with high-dose cocaine and amphetamine users have no doubt seen people who've developed paranoid psychosis that looks, for all intents and purposes, like paranoid schizophrenia. How many of you have seen that? Okay, a lot of you have. So if I were to ask all of you, you can just call this out, how long do you think it takes of regular high-dose cocaine use to have your first psychotic episode? All right, how many people would say 3 months? Show of hands. Yeah, the first answer is never right. How about 6 months? How about a year? Okay, so it turns out it takes anywhere from 6 months to a year of chronic high-dose amphetamine or cocaine use to have your first psychotic episode. So how long do you think it takes to have your second psychotic episode? Usually it's the first dose, but it's almost always within 48 hours of a relapse. So what and this is true whether the person's been abstinent for 6 months or 2 years. So that the important part of the sensitization is that the brain appears to be healing. That is, you talk to them, they're not psychotic, they go about their business, they work, they form relationships, and then a year later they go to a party and somebody's, cutting some lines and they say, it's been 2 years, I can have a line. And then the next day they're completely psychotic and the next day they're in the hospital. So the important point here is that again, just like tolerance doesn't develop the same way in every part of the brain, there are parts of the brain that can be sensitized to drugs where full reversal probably never occurs. And we know from animal studies, and I have to confess, I don't really know how you tell whether a monkey is psychotic, but they do these studies with monkeys. And yeah, but okay, so we'll suspend disbelief. They know when a monkey is psychotic. 6 years later, they can show they have the same level of sensitization as they had 6 years earlier. So that's an example of the fact that although there is stabilization and no doubt some amount of healing that occurs in the brain, this notion that the brain is completely healed after detox is malarkey. It's simply not true. And it's not true for any drug. So if you look at alcohol, a year after people stop drinking, a majority of people still have sleep disturbances. And when you do sleep encephalograms, these PSGs, what you see is abnormal sleep. They have more frequent awakenings, more frequent sleep stage changes, less stage 2 sleep. So again, this is a year later. So when we talk about it, we talk about mind, body, and spirit as though, well, the body part's over in a week. This is simply not true. The body part goes on and on and on, and probably is part of the reason why relapses in that first year are so common. Impulsivity is an interesting one. You can measure various kinds of impulsivity in addiction. And it turns out that even 6 months later, people who have increased impulsivity in addiction in these tests still have it, although it's about half as bad as it was when they first detoxed. So again, this impulsiveness, which drives drug use and other dangerous behaviors, doesn't go away just because a person is 3 or 6 months out from using. Lots of examples. This is just a PET scan. This looks at this is a normal healthy control, and this is the activity in the dopamine receptor system in a normal healthy control, and this is in a chronic drug user. And what you can see is that there are marked changes in the number of receptors as a result of chronic cocaine or amphetamine use, and most importantly, even 6 months later, their brain will look much more like this than like that. So addicts' brains, the effects of drugs are long-lasting and at times permanent. Functional stability, that is looking good, having a normal conversation, behaving normally in the world, is not the same as neuronal recovery, as the nerve cells being healthy again. That rewiring of drugs, rewiring of brain functions by drugs is both real and measurable. When I was a kid, because they didn't have any of this neuroscience, you'd have this commercial on television. This is your brain, and then they would crack the eggs on the frying pan. This is your brain on drugs. And we laughed because it was ludicrous. But it turns out it was right, that there are irreversible changes. You can't uncrack or unfry that egg, and that we can help to restore function. It's not that we should be hopeless and that recovery doesn't occur, but it isn't what we've been taught. It isn't as though this miraculously reverses 100%. So the brain heals, and relapse rates markedly decline over the first year. That's the really good news, that a lot of what we do, we need to focus on the first year as the mantra, not the first week, not the first month, but we have to think about what does treatment look like for the first year, because by the first year, most of the recovery that's going to occur has occurred. So in the first year, relapse rates are very high. After the first year, it's about 10% per year, which is not great, but it's certainly better than in the first year. So why don't we take a break for a few minutes? I thought I'd open it up to some questions and then let you guys go out of the room. I see a couple of you getting a head start. Yeah. Why don't you hold on one second, because Mo's going to bring them.
Don't leave yet. We're going to take a break in 5 minutes.
5 minutes.
Hi. So whatever the chronic drug use, you're saying that it's hard to reverse the effects. That would be very depressing for somebody that was in treatment. But it could be, it is altered. Behavior can be changed. So a way to reframe that.
So again, this is a professional audience, and I'm trying to make a point. How I would frame this for a client is a little bit different. But I want to explain the point here. When we have people in early recovery, they often look really good. They're eating better, they're sleeping better, they're going to meetings, they're feeling the sense of social support, and because they look so good, we assume they're out of this period of risk. And really what I'm saying is that it's all lurking below the surface, and that we cannot take for granted their improvement. So when I work with clients, and again, because of my role, I'm mostly here and there. I don't have long relationships, but for many years I've done a psychopharm group, or medical addiction group really, in Malibu. The message that I've tried to say is, look guys, you may feel great and you may not feel like you need to be on one of these medicines, but your brain is not great. And the role of these medicines are to get you to the end of the first year. You keep telling yourself, I just screwed up. But this is not that you just screwed up. This is that your brain's dysregulated and it's not working with you on this. And so getting people to accept treatments that they're skeptical about or reluctant to take, part of it is to explain what the problem is. You know, and I think that most people who leave acute treatment are what I would call blue skying it. You know, blue skies shining on me, nothing but blue skies do I see. And we have to prepare them, and they are not prepared if we don't teach them about this. Yes. Any other questions before we break?
Hold on.
When you talked about detox actually increases the chances of overdose, could you clarify that a little more?
It's exactly that. The answer is that what happens when you detox someone is you're reversing their tolerance. You're stopping the drug they were on. You're then going to taper and discontinue the drug you're using to prevent the medical complications of the withdrawal system situation. And so within a period of days, usually 5 to 7 days later, that person has no tolerance to the medicine. So if they were able to tolerate 3 bags of heroin, they're going to overdose on those 3 bags because they have no tolerance. So they're going to stop breathing and they're going to die. So part of the thing that we have to recognize is that the treatments that we're using are actually increasing their risk. It's not a metaphor.
Anybody else? Take a 10-minute break, be back at 10 after 10.
So it brings us to the point here, which is that if you want to arrive at a destination, you first need to know where you're going. And I don't say that facetiously. So I think that one of the questions in addiction is just as we don't agree on what addiction is, we also don't agree on what success is. So if I were to ask all of you, what is success in treating someone with an addiction, what would you say? Not a trick question, guys. Long-term abstinence, is that from one drug or multiple drugs? Okay, so this is really the recovery view of successful treatment, is all drugs all the time. What are other measures of success? Stabilized lifestyle. What else? Staying on track. Coping skills. Yeah. So again, you will never hear me ever use the words harm reduction. Why is that? Well, if you think about any chronic medical condition, and addiction is a chronic medical condition, that the goal of treatment is always harm reduction. How many of you are taking either a statin or a hypertensive medicine or both in this audience? Yeah, I'm taking both. I don't expect to be cured of my hyperlipidemia by taking a statin. And I don't expect my blood pressure to go away because I'm taking losartan. The role of chronic medical treatment is to prevent further consequences. I take these drugs because I don't want to have a stroke or a heart attack or peripheral vascular disease. The whole purpose of taking them is to prevent harms. So when you think about chronic medicine, you're thinking about preventing harms. That's what we're doing. Now, if you're a surgeon, you may be able to cut out the problems. A friend of mine once said a surgeon is someone who thinks he can fix a car by just taking parts out. But the truth is that in every other area of medicine, we have few cures. And if you think about cancer as an example, because there are people who we might think about as being cured, that when oncology became a serious field in the late 60s and early 70s, people had to come up with a new definition of success because they couldn't have cure as the success. So they toyed with different measures of success. And that's really how we got to 5-year survival. When people talk about a cancer cure, they're talking about 5-year survival. Now they talk about 10-year survivals. They don't talk about actually curing the cancer. So that the idea that we're preventing future harms is the focus of all treatment in medicine. And so when we denigrate a treatment by calling it harm reduction, we're missing the point. Now, harm reduction has a history to it. When methadone first became available, the people who were developing it realized that methadone was not consistent not only with the recovery community, because the importance of the recovery community in addiction treatment was much less in the 1960s than it is today, but they were worried about the psychoanalytic community. that looked at treatment in terms of going to see a psychoanalyst 3 to 5 days a week, talking about your problems, and resolving intrapsychic conflict. And by that standard, methadone was not a treatment. You weren't going to resolve intrapsychic conflict by taking methadone. So they looked for a way to describe it that would minimize the adversity it would face in trying to get it into the community as a treatment. And that's where the term harm reduction came from. But it is anachronistic and it's no longer appropriate. That we need to think about treatments not just in terms of cures, which are great but are rare in medicine, but also in terms of preventing future harms. So now I'll get off my soapbox. So what are our measures of success? So continuous abstinence is one of them, but another measure of success that's widely accepted in other countries is reduced use. The number of abstinence days, the number of heavy drinking days, the number of binges, the number of drug-free urines, all of these are used as outcome measures in clinical research involving addiction. So the theme here is reduced use. Retention in treatment. The primary outcome measure in most heroin and opioid studies is retention in treatment. That is, the person continues in treatment. Not how many drug-free urines, not how many drug-free days, but that they keep coming back. And that's a really interesting measure, and it results in a lot of distortions when you think about it. But it turns out that if people keep coming back to treatment, even if they continue to use, they're less likely to be incarcerated. They're less likely to develop HIV and other complicating infections. They're less likely to commit crimes. So coming back is an outcome. Quality of life, we heard this from the audience. Employment status is frequently looked at. Are they working or not? Because in our society, if you're not working, that's a really bad sign. You're not contributing. It's indicative of a level of impairment that's very severe. So if that's how we measure success, how do we measure treatment failure? Again, not a trick question. Okay, the reverse of all that. Well, yes and no. So probably, death is a real treatment failure. Overdoses, suicides, and all-cause mortality. We talk about overdoses because we're in an epidemic of overdoses, but the second leading cause of death among people with substance use disorders is suicide. So if we had more time, we would talk about that too. Incarceration. One of the outcome measures that's frequently used in opioid studies is, are they in jail or not? Medical complications, HIV, Hep C, medical hospitalizations. So people talk about relapse in terms of continuing drug use, but even here, there's very little agreement. Are we talking about continuing drug use for the drug they were addicted to, that is the target drug, or are we talking about continuing drug use for other drugs? And this has become an increasing question with the legalization of marijuana. Do we need to be as concerned about the former heroin addict who's still lighting up a joint on the weekend as we would if they were using heroin? If you're taking a view that abstinence is all drugs all the time, you would say absolutely. But if you're looking at this from the perspective of preventing future harms, you might say, well, wait a second, marijuana is not heroin. So I think we have to be thoughtful about what our beliefs do to how we think about success. And finally, where there is agreement is that most people would agree is that if there is a relapse back to the previous pattern of use, whether that's gambling or sex or heroin, that's a relapse. Does this make sense to everybody? Okay. So this is the most important slide in this deck, conceptually. And what this is about alcohol, but it turns out the data, if anything, is worse in some ways for opiates. So it's going to make the point. So this is two views of how treatment works. And this is not from our centers, but this was a very large retrospective study that was looking at relapse. And the subjects in both of these slides are the same people. So I want you to understand these are not two different groups, it's the same people. So let's start with the first slide. This slide is really this slide, is it on now? Okay, we're getting better at practice. Okay, so this slide is the abstinence view of success. What you have here is day 0 is the day they're discharged from a treatment program. So these are really good programs. Everybody's abstinent on the day they discharge, because if they were using, they'd have kicked them out. Not hard to achieve. Okay, so then this is the time axis, 90 days, 180 days, 270 days, 360 days. The open circles are people who went through residential or inpatient treatment, and the closed circles are people who went through outpatient treatment. And you can see that from the decay curves that this is not a very happy story. So that by day 60, about 60% of the people who went through outpatient treatment have had their first drink. About 40% of the people who've gone through inpatient treatment. Then by 180 days, only about 20% remain that haven't had their first drink from outpatient, and basically 30%, 40% from inpatient. And at the end of the year, 20% are continuously abstinent following outpatient treatment, and about 30% are continuously abstinent following inpatient treatment. How do people feel about this slide? Kind of sucks, doesn't it? Well, before we go to the second slide, I want to make a couple of points. The first is that people who are referred or self-attend recovery meetings in the community, and again, it's hard to get accurate estimates, have about a 10% success rate at the end of the year. So people who try to do 90 meetings in 90 days and stay sober for a year, about 1 in 10 is successful. So if you use that measure, then people going through inpatient treatment have 3 times the success rate of people going to meetings on their own, and about twice the success rate of people going to the meetings on their own if they go through outpatient. In any other area of medicine, this would be considered a huge treatment effect. If you doubled survival rates for lung cancer, that would be really big news. So it's really only in our field, because we have this notion of these disorders being so much more treatable than they are, that we find this so depressing. Even so, it's hardly anything you want to celebrate. But this is not the whole story. And I put this slide up here because I wanted you to see how this is not the whole story. So now we're going to look at a different view. Remember, these are the same patients. So what this view is that it's a measure of use. It's the number of drinks per drinking day. This study looked at drinks per drinking day, days missed from work, total amount of alcohol consumed. All the slides look the same. I just had to pick one of them. So it's the same subjects, only this is not I want to make a point before I explain it. This is not an arithmetic average. In this part of this deck, we're only looking at the people who, when they were called for their follow-up interview, said, yes, I'm drinking. So it doesn't include the abstinent people averaged with the people who are drinking. These are just the people who said, yes, I'm drinking. It's really important. So this was day 0. Here, the slide that we're interested in starts at 3 months later. But what you have is that this is the 3 months prior to treatment. So this was 3 months prior to treatment, 1 month prior to treatment, and then this was their baseline rating. And so what you can see here is that these were really alcoholics. They were drinking on average 20 drinks per drinking day in the inpatient group. I don't think any of us would have trouble saying, yep, that's an alcoholic. And the outpatient group was really not much better. They were on average drinking 15 drinks per drinking day. I think they took their job seriously. So what happens? So at 3 months, what you can see is that there's about a 70% reduction in the number of drinks per drinking day for both groups. It's a little bit better for the inpatients, but really by about 6 months, it's the same for both groups. And what you see here is that compared to where they started, it's somewhere between 60 and 75% improvement in the number of drinks per drinking day. And when you look at the health claims data from people who've been through treatment, even though 70% are using at the end of the year, their health complications have reversed, their days missed from work have gone down. Treatment makes a huge difference in the course of this illness. But what it doesn't make a huge difference in is abstinence. Continuous abstinence is not the measure that is most responsive to treatment in the first year. The measure that's most responsive to treatment in the first year is the amount that people use. That what happens in treatment is that people realize they have a problem, and that they realize there is a need to make changes. This is if you think about this from a motivational interviewing perspective, what's happening is that going from being pre-contemplative or contemplative to action. They're taking steps, they're making changes. It's just that those changes may not be sufficient to result in continuous abstinence. So that we shouldn't hang our hat on continuous abstinence as the impacts of treatment. And this has very big implications when you start to compare drugs like alcohol to opioids. So the good news is that treatment works by increasing abstinence rates. There's no question they're 2 to 3 times higher as a result of treatment than they would be without it. But where there's really a marked improvement is in the amount that people use. There's a 50 to 60+% decrease in the amount of consumption, and that all the other social measures improve. Work attendance, self-reported quality of life, healthcare utilization are all markedly improved by treatment. I wanted to just share a couple of slides from a 4-center outcome study that we did at Elements. This involved 4 of our treatment centers. At the time, that's all we had, so it was everybody. And these were sequential admissions, so anybody who would sign the consent form was included in the study. And there were no dropouts. Anybody who was enrolled was followed for the entire duration of the study if they could be reached. So if people left AMA during the acute treatment, they were still counted. So this is the data for 4 centers, 300 subjects, roughly. It's in press, but I don't have the most recent reference. So we looked at lots of variables. We looked at age, gender, sex, educational levels, types of drugs used, the number of meetings people went to, previous treatment episodes, all these kinds of things. At the end of the day, none of the demographic variables predicted success. I'm going to say that again. None of the demographic variables predicted success. They did predict whether people completed treatment. More educated, affluent people were more likely to complete treatment in the acute phase. It didn't predict success. So we basically enrolled people within 5 days of admission. We did a baseline assessment in person, and all the follow-ups were done by telephonic interviews. We had an informed consent because we knew we were going to publish it, but we also wanted to be able to pay them $10 to participate in the follow-up interviews. So once you're paying clients, you have to have an informed consent. We had to come up with a definition for discharge because many of our centers have multiple levels of care. So the person might start off in detox or residential and then go to IOP. So we define discharge, discharge at any time you're coming to treatment less than 3 days a week, because we're an acute treatment center for the centers at that time. So we were basically saying if you're coming less than 3 times a week, this is just outpatient treatment. It's just not what we're measuring today. So this slide just shows that there is a problem with retention, that at the end of 1 month, 30% are lost to follow-up. And that number is pretty stable for the rest of the study period. We were measuring things for 6 months. So although the specific individuals that are in this 30% come in and out, that there is a group of people who leave treatment that are highly vulnerable to relapse in that first month. What you can see is that our centers vary dramatically in the age of the client. So at the recovery place, it was 27. At Malibu, it was in the 40s. West LA, which had our young adult program, was 24. So there were very big differences in the ages, in the educational levels, not so much in the gender, and huge differences in marital status. This is the 6-month data. What you can see is that at baseline, people have very few abstinent days. And so this is % days abstinence total, means that the people who came into treatment were using 80% of the time. And for drugs, it was about 60%, and for alcohol, it was about 40%. In this study, we included anybody who used alcohol for all groups. So there are people who were not necessarily alcoholics, but where it was their secondary drug of choice, which is why the number is lower. But if you look at the amount of use, you can see that these folks are serious about their drug use. And what you can see is that at 1 month, and these are for the different drug categories, it was about 97% abstinence. At 3 months, it drops a little bit, and by 6 months, it's in around the 90% range. And again, we looked at the different programs, and what you can see here is that the outcomes were virtually superimposable. We also looked at other measures, because one of the things that always happens is people who have a strong bias toward continuous abstinence have a hard time believing that anything good can happen in people who might occasionally use. So we looked at other measures. So again, 90% days abstinence means people are rarely using. It doesn't mean they're never having a slip, but it means that they're engaged in treatment, they're participating. And what you can see is that there was a marked reduction in their depression. It starts off with a fairly high depressed score, and by 6 months it's remained subclinical. The reason depression is so important is that people with clinically significant depression have somewhere between 4 and 10 times the risk of relapse of other patients. So depression is a very important predictor of who's going to relapse. Quality of life improved. A 1-point change on the scale is huge. You almost never see a 1-point change when you use the scale in schizophrenia studies. So, clients who enter treatment at one of our facilities can expect to experience sustained improvements. The programs achieved similar outcomes despite differences in demographics, length of stay, price, and the clients showed corresponding improvements in mood and quality of life, suggesting a broad impact in treatment on their well-being. We achieved the same outcomes for alcohol and other drugs. So amphetamines, cocaine, opiates didn't do worse in that first 6 months than alcohol. So you may be wondering now, if they do about the same, that is, if alcohol and opiates are doing about the same, why am I giving this lecture? And the answer is because they weren't 100% abstinent. So the problem that you have is that if someone sporadically uses a drug, the outcome is very different if it's alcohol versus opiates. So let's look at this. Whoops. So with alcohol, overdose deaths are rare in alcoholics. Who overdoses from alcohol? College freshmen, high school students. They don't know how much to drink, they have drinking contests, and they overdose, they get alcohol poisoning. But it's not, for the most part, it's not alcoholics. In the case of opiates, overdose deaths are common and they're increasing. In alcohol, we do have a couple of treatments that are thought to be somewhat effective. Naltrexone, acamprosate, Antabuse. But the truth is, when you actually look at those effects, they're very mild to minimally effective. And we don't have time to talk about it, but although these drugs are used, very few clinicians or professionals in addiction space would say, oh, it's totally different when that person gets naltrexone. Now, it is different, but it's not like totally different. Whereas the pharmacotherapy, and we're going to talk a little bit about this, for opiates is moderately effective. So you have to always ask yourself, do I use a treatment that works versus do I not use a treatment when it doesn't work? And if you look at this, in terms of other addictions, we have no effective treatments for amphetamines. We have no effective treatments for cocaine. So, in this context, it is relevant that it's one thing to have an abstinence view of the world if there's no effective treatment. In other words, that you're not giving up anything. What changes it is when there are treatments that are moderately effective. Oops. Okay. Treatment decreases craving and it decreases reward. So the medical treatments that are available for alcohol seem to have their primary influence on craving and a little bit less on reward functions. With opiates, you're talking about completely blocking the high or inducing massive tolerance that prevents the person from enjoying the drug. So the magnitude of the benefit in opiates is far greater because of how they work. When you look at alcohol, a whole range of psychotherapies are effective. Just about every therapy that's been studied seems to be effective in the first 6 months of treating an alcoholic. And that includes CBT, motivational interviewing, interpersonal therapy, couples behavioral therapy. All of these are effective in alcohol. But when you look at opiates, it's really only contingency management and community reinforcement that have been consistently shown to be effective, and to a certain extent, CBT. So that the accessibility of opioid addicts to therapies seems to be less. Now, there could be better studies, but I think it's important, again, to realize that here we have a lot of options, including 12-step facilitation, CBT, MI. In the world of opiate dependency, therapies seem to have less effect and less benefit. overdose deaths rarely occur with alcoholics. If I relapse, I may die eventually, but it won't be from alcohol poisoning. So it may be a car accident, it may be liver failure, but it will not be alcohol poisoning. So that you have a very different situation than you have with opiates, where, as you saw earlier, the peak incidence for overdoses is within 2 weeks of a relapse. So that person who says, I'm just going to get high at this party, may not get a second chance. So it's not that one responds to treatment and the other one doesn't. The time course and the patterns of responses may be more similar than different. We don't have time to look at every study. But what is different is that incidental use, the occasional slip, that is not medically dangerous or complicating for an alcoholic. It may cause them to go into a full relapse. I'm not saying we shouldn't worry about it, but it doesn't have the same immediate and catastrophic consequences as when an opioid-dependent person slips. Does this make sense to everyone? Okay. So we've seen this slide before, and again, it's just a reminder that people slip early on. So, what do we know about the epidemic that we're in now? And this slide is a couple of years old, but it's such a great slide I couldn't help myself. So what you can see here on the left is, and remember, in the federal registers, they talk about drug poisonings, not overdoses. So that's why this says drug poisoning, but wherever you see drug poisoning, say overdose. Okay. So what you can see is that in 1980, when almost all the opioid use was heroin, not prescription opioids, the number of overdoses was very low. And that over the next 20 years, it quadrupled, and today it's over and around 50,000 range. And that what you can see is we've done a great job in making cars safer. We've had it's actually cars are down here now. So the number of motor vehicle deaths has dropped significantly over the same time period that overdose deaths have overtaken it. On the right, what you see is the role of pharmaceutical manufacturers and the medical community in creating this epidemic. This is entirely an iatrogenic epidemic, meaning it's a direct result of changes in physician practices. And what you can see here is in 1999, we were still afraid of pain medicines. And that over the next 20 years or so, 10 years, the number of prescriptions written has increased exponentially, and the number of deaths have increased. And the number of people in opioid treatment has increased. These are all highly correlated with one another. So
Excuse me, is that 80%, 70, 60, 50?
I'm sorry, it's the rate per thousand. It's, so I think it's per thousand. Could be, yeah, it's per thousand. So what you see here is that something changed, and that something was how the medical community viewed pain. That prior to the 1990s, most clinicians were afraid to use opioid pain medicines because you could become addicted to them. And then they started to use them because there was a sense that they weren't as bad as we thought they were. And this was really based on treating chronic pain in cancer patients with narcotic analgesics. And in cancer patients, addiction rates are very low. A lot of them die before they become addicted, but they are low. And so we started to use pain medicines for things like fibromyalgia, multiple sclerosis, migraine headaches. Honestly, I went to the doctor, I had stubbed my toe, and he gave me 60 Vicodin. I said thank you. The point here is that they became ubiquitous. And this is not the first opiate epidemic that occurred because of changes in prescribing practices. In the United States in the 1890s, who do you think the typical heroin, morphine, it wasn't heroin in those days, it was morphine. Who do you think the typical morphine addict was? So in the 1880s, it was still people coming off of the Civil War. They were people who had had amputations and injuries in battle and had been given, opiates and opium and then morphine for their pain and had become addicted. So the kind of addict that you saw in the mid-19th century was typically someone who had had pain, usually from a traumatic injury, and then had this post-surgical pain if they lived, and then they became addicted. But what did the addict of 1915 look like? Housewives, absolutely. It was housewives. It was predominantly female 30-year-olds being treated for menstrual cramps and migraine headaches. And so my theory is about every 100 years we choose to forget how addicting opiates are. But it shows how easy it is for that to occur. You know, and so this epidemic is not unique, but it's certainly the worst. So I thought it's worth talking about, you know, overdose risk in the context of who's taking opioids today. And so, you know, if you look at overdoses from all causes, men are at greater risk than women. And although we don't know what accounts for this gender bias, some of it may be risk-taking, that in some studies of impulsivity, men score higher than women in impulsiveness. This comes as a great shock to everyone here. And, you know, not surprisingly, young men are particularly high risk for overdose. And again, this seems to be related to this impulsivity. So again, you know, as we go through this, what I'm hoping people will start to ask themselves is, you know, what is the framework of treatment, and how does this risk mitigate or mediate what we choose to do with and for clients? So it turns out that there are some behaviors that do increase the risk of overdose. So if you look at client behaviors, and we talked about this a little bit, injecting drugs increases your risk because of the pharmacokinetics of the drug, that it makes it more likely that you'll overdose. But it turns out that the more you shoot up, the more risk you have. So anytime someone shoots up more than one time per week, so we have a lot of mixed drug users. They'll use heroin if they can't get OxyContin, you know, they'll use fentanyl and they'll shoot that up if they can't get heroin. But the bottom line is if someone's shooting up more than once a week, their risk of overdose goes up significantly. Another factor is the problem of other drugs. Now, it's really interesting because, you know, most of us know that alcohol depresses the respiratory center, you know, because most of us have passed out at a party and people were checking to see if we were breathing. And I know it's never happened to any of you, but. And benzodiazepines, you know, also suppress the respiratory center. These are drugs like Xanax and Ciarex and Ativan and Klonopin. You know, all of the benzodiazepines have some respiratory suppressing effects. So it shouldn't surprise us that when you look at overdoses in the 2000s, that we often see alcohol and benzodiazepines present. What's interesting is cocaine also increases the risk of overdose. And cocaine has no effect on the respiratory center. So how do we think this happens? So why is speedballing so dangerous? And I think the answer is that when people use cocaine or amphetamines at the same time that they're using opiates, they can't tell how high they are, that it obscures some of the sedation and anxiety-reducing effects of these drugs, and it stimulates arousal and attention. So the person has the misperception that they're not as loaded as they are. The problem is that arousal doesn't affect the breathing center. So they get compensation in their wakefulness, but they don't get compensation in the respiratory center. You know, the other behavior that's consistently linked to an increased risk of overdose is arrests. So people who are arrested for things other than simple drug possession, because they all get arrested for drug possession or DUIs. So this is, you know, somebody who's muling drugs to get money to pay for drugs. It could be somebody who's breaking and entering to get property to sell. But in any case, arrests, prostitution, things like that, increase the risk of an overdose. But there are a lot of treatment factors that increase the risk of overdose. One of them is the number of treatments in the last 12 months. So all of us, when we take an admission, biopsychosocial, we ask about people's treatment history and we write it down. And usually that's the last time we give any thought to it. Whoops. Here we go. And that's the last time we give any thought to it. But the thing is that people who can't complete treatment have something different about them. And that what that difference is, we don't fully know now. We don't know if they have more persistent psychiatric problems, ADHD, depression, bipolar disorder, or if they have more severe addictions, that they're higher drug users. But consistently and across studies, the number of treatments in the last 12 months is a significant predictor of overdose. So when you take a history and someone says, I was in treatment here, and yeah, I did 18 days, or I finished 30 days, but then I started using a week later, and then I was in treatment in this other place, and I started using 2 weeks later, that person rings the bell. They're already there, because for whatever reasons, people who are not able to maintain any improvement after treatment are at a much higher risk for overdose. Length of sobriety following treatment. Any period of sobriety less than 6 months is a bad predictor. In other words, it significantly raises the risk. So again, I think that as we talk to people, we have a disconnect today in this field between what we know about them and how we use that information. So part of this is to recognize that we have different levels of risk among the people that we treat, and that the person who has failed multiple treatments and has short sobriety following treatment is in a different boat than almost anyone else. And then in terms of treatment, the person who gets to ring the bell is the person who's had an overdose in the last 6 months or ever. In other words, the highest risk is if it's in the last 6 months, but anyone who has ever had an overdose is significantly more likely to have an overdose again. It doesn't matter how long has transpired. Any questions about this before we go on? Okay. There are a lot of people who overdose at home and don't get treatment. So, again, getting back to the earlier definition about what an overdose is, the fact that they needed treatment is really what you want to find out about, not necessarily whether they got it. So if somebody, had a friend who tried to raise them and stick them in the shower to keep them awake, that counts as an overdose. It's the fact that it was probably useless and didn't, make a difference notwithstanding. So we want to recognize the need for treatment as the threshold, not the actual getting of treatment. There are symptoms that are associated with overdose, though. And there are 2 symptoms that people have during treatment that are significantly correlated with future overdose risk. One is craving intensity and frequency. And we talked about how painful craving is. And we now tend to think about craving as drug-induced cue responses. One of the things that happens that once somebody's become addicted to a drug is that cues that would not otherwise cause stress. So the notion here is that if you take someone who's been addicted to heroin and then 3 weeks later present them with a picture of a needle and the works, their magnitude of stress response will be very high. In fact, the amount of stress they experience from just looking at a needle is as high as it would be for, let's say, someone going to work and having their boss yell at them. It's extremely distressful. And so when we think about cravings, we tend to think about them now as this intense cue-induced stress response. And people who describe having cravings are at a greater risk to overdose, probably because they can't resist that urge. The second thing that seems to predict overdose risk is readiness for change on admission. That as people who come in and who are the least prepared or thinking the least about treatment are the most likely to overdose. And so if you think about that from a trans-theoretical model, many of those people are pre-contemplative. They don't really believe they have a problem. They were just pushed into treatment by a set of circumstances. They may have been arrested, they may have wrapped their car around a tree, their boss may have fired them, their wife may have walked out, but they weren't really thinking about getting treatment at the time they started. So in our scale, for instance, we're measuring using 2 simple visual analog items to measure those 2 symptoms. So the readiness item, you can see, it's anchored by I rarely or never think about quitting. Someone who scores down here, not a really good sign, versus, I'm now trying to quit using drugs or quit drinking. So you have a scale where, the person can kind of say how ready they are and how much they've traveled in terms of their motivation. In terms of cravings, it's not at all, hardly noticed, occasionally, And we only score it if the person says frequently or nearly all the time. So we developed a simple scale, a 21-item scale, that took all of these factors that we've been talking about and said, I wonder what the next 100 clients is going to look like in terms of their risk. And then, being a dabbler, I couldn't resist assigning weighting to it. So someone who had a previous overdose attempt got 5 points for that. For a recent overdose attempt, it was 5 points. But the weighting wasn't really important. The idea was that we wanted to have a measure that our staff could look at and say, whoa, now this person's at higher risk. And so this was from the first 100 or so clients that we administered the scale to, and we did this at 2 different centers. And what you can see is that there's a group down here that seems to be at relatively low risk for overdose. And interestingly, these were almost all clients who had gone to pain treatment centers for chronic pain, had started using the pain medicines, and then had sort of gotten into the cookie jar. In other words, where they started taking more than was prescribed, developed a dependency. But for the most part, they were older, they weren't using other drugs, they were generally compliant with medication, they had not failed in previous treatment, so they were down here. And there's another group where, they seem to have moderate risk. I don't think you can say that on a score of 8 they have no risk, but who probably don't correspond to a very high-risk group, this group under 10. They score on some of the items. They may have been arrested. They may have had one previous treatment in the last year. But again, not as high risk. And then you have this group. And this group, for the most part, have had previous overdoses, multiple treatments, very little abstinence following treatment. And I think that the point here is that in every other area of medicine, we stage the severity of the condition, and then we develop treatment approaches that are consistent with the severity and the risks associated with it. So if you think about cardiovascular disease, if someone needs a stent, we don't put a stent in an artery that's open, we put the stent in the artery that's closed. If you think about cancer, a very common procedure in most cancer therapy is to stage the cancer. We cut people open, we biopsy lymph nodes, we get an overriding picture of the scope of their tumor, and then we decide the treatment. In our field, we often decide the treatment before we stage the disease, and that's the part that's going to need to change. I see some people nodding. Yes, okay. So we need to look at this group differently than we look at this group. And I'm not sure yet what to do with this group. So we're going to pretend they don't exist. Okay. So key observations. So then we looked at what was going on in the first 100 or so people that we gave the opioid scale to. And these were all people specifically admitted to treatment for opioid dependency. So we weren't giving the scale to alcoholics. It was just to opioid-dependent people. And what we found was that 30% of them had past overdoses, 35% were IV users, 60% were using benzodiazepines along with their opioids, 40% had been arrested, and 40% had failed treatment, almost all of whom had failed within the previous 6 months. So this seems to be what drives the score. So just coming back to the ATOS trial, which I talked about in the first hour, they continued to follow this group up they've already published 3 years and 7 years. They just published the 11-year data. And I wanted to comment a little bit on how our data relates to this 11-year study. And again, this is all part of how do we stage people and how do we make decisions that are appropriate for them. So in the ATOS trial, they continued to follow those 4 groups for 11 years. And what they found was that lots of people went through lots of different treatment. People who started off in detox only wound up on opiate agonist therapy. People who started in residential went to opiate agonists went through detox. So there was a lot of fluidity that went across the treatments over time. Not in the first year, but often if you looked at this, by 7 years, almost everybody had had multiple treatments. So what did they learn at 11 years? Well, probably the biggest thing they learned is that depression is a really bad thing to have if you have heroin addiction. That if someone is depressed, they have twice the risk of dependence at 11 years. If they have borderline personality, they have 1.5 times the risk of dependence. So having depression is a very negative predictor. And they looked at lots of other variables that simply weren't very powerful predictors. The good news, and this gets back to what I was saying earlier, is that time is on our side. If we can keep people in treatment, outcomes improve. But we've got to open that window up. So heroin dependence at 11 years declined from 97% to 15% at 11 years. This is huge. I mean, think about that. We're now getting almost 6 out of 7 going the other way, doing well. So it isn't that treatment doesn't work, it's that it takes a lot of time, and it takes multiple treatments. And so that, part of what we have to move away from is this notion of one and done. And that the other thing that remarkably declines is overdose risk. In the year prior to the study starting, so this is when they were not in treatment, there was a 25% incidence of overdoses. So 1 out of 4 people they enrolled had an overdose in the previous year. And by 11 years, it was 4.9%. So 80%, so it's remarkably similar to the dependency data, did not have an overdose in the year prior to the 11-year follow-up. So risk is real. Depression is another negative predictor. But that what really comes out of this is the need to plan treatment over an extended period of time. That more important than what we do in the first week of treatment is what we do at the discharge planning phase of treatment. How do we continue treatment, and where are they going, and how are we selling that? Because many of our clients are going to feel they've got it covered and they're in control at the time they finish their acute treatment. So, major depression influenced outcomes in a negative direction in every measure. They were more likely to use heroin, they were more likely to be heroin dependent, share needles, and be criminally active, and that the relationship to depression was stronger than any of the other outcome variables. The reason I mention this is that, when I first started doing work in the addiction field, the first thing I noticed was we had a lot of people who were addicted or using drugs and very few beds. So if you go back to 1980, 50% of the people who were being screened for admission at the VA hospital and at Harbor General needed treatment for drug or alcohol problems. And at that time, less than 10% of the beds were specifically allocated for that purpose. Today, we have a different problem. We have very aggressive management in many settings of co-occurring disorders. That is, there is diagnosis, there is treatment, there are multiple drugs. I have centers that I think are probably sending people home on 3 and 4 different medications. But what there is terrible follow-up. That the clients leave not understanding that depression, just like addiction, is a recurring disorder, that medications are necessary for most people to stay well. If they've had 3 or more episodes of depression, they're not going to get well on their own. And that the education around maintaining treatment for chronic depressive disorders and anxiety disorders is simply not driven home. So I wanted to talk a little bit about what works. It turns out that standard treatment works. 12-step facilitation, followed by counseling and community support makes a difference. In our hands, we saw that 90% were abstinent at 6 months. So it's not that abstinence-based treatments can't work. It's that they carry special risks. If you look at all the studies that have ever been published, longer treatment is always better than shorter treatment. But what's interesting is that the setting in which that treatment occurs may be less important. So if someone starts off in a residential treatment setting because their life is too chaotic to be treated in an outpatient setting, it may not matter after the first couple of weeks how many weeks they get residential treatment versus how many total weeks of treatment they get. And unfortunately, even outpatient programs today are mostly episodic treatment. That is, that the focus is on getting them through the first 4 to 8 weeks. They're looking at the number of visits per week and whether their urines are drug-free, but they're not really saying, this is a year-long treatment, and what I really need to be worried about is what am I doing with them after the first 8 weeks? And how many times are they going to be seen a month? And what's the treatment process for the people who are not in the acute treatment phase anymore? And most treatment centers do nothing with that. They say, well, we have an aftercare group that they can come back to. But here's the problem. Aftercare is not treatment. If there's no chart and there's no medical record and there's no one accountable, it's not treatment. So we need to understand the difference between aftercare and treatment. but longer treatment is always better. Urinary drug monitoring is also always better. And if you can pair urinary drug screens with rewards and consequences, it always improves outcome. This is the basis for drug courts. Drug courts work because there's a relationship with the client and they get immediate feedback and consequences if they test positive. Physicians programs and pilot programs work because there's ongoing urinary monitoring associated with rewards and consequences. This is what finally and ultimately improves long-term outcomes for many people. You know, the problem we have in addiction today is that there is no single treatment that works better than about 40% of the time at 1 year. I didn't want to spend this whole talk talking about methadone versus buprenorphine versus long-acting injectable naltrexone, but the truth is methadone, which is the single most effective treatment for opioid dependency, only has about a 40% retention rate at 1 year, and everything else is less. And that we need to be aware that reduced use is more common and more stable than abstinence in the first year following treatment. So that we have to design programs that educate people about this risk, and we need to offer treatments based on whether or not we think the client we're working with is in this group that's more likely to have these lapses. What doesn't work? Detox by itself. There are no medications for cocaine and stimulants. Oral naltrexone is not effective for opiate dependency. It actually increases overdose risk, so we shouldn't be using oral naltrexone for dependency. The other thing that doesn't work for dependency is naloxone. There's a big push to get naloxone into every household of every addict in the United States. This is the auto-injector or nasal spray that can reverse an overdose. But here's the problem. If you're comatose, can you give yourself naloxone? So you have to hope that the person you're getting high with is not also overdosing at that same moment, or you're not going to get any benefit. Naloxone may not be a bad idea. You know, if you're a parent and you have an addicted kid who you're letting live in your house, you probably should have naloxone, but I don't think we should mistake it for treatment. And finally, you know, in medicine, there's been a big push to have a treatment in general medicine called screening, brief intervention, and referral to treatment. And SBIRT is fairly effective for alcoholism. That is, when people get SBIRT from their family doctor, their likelihood of getting follow-up treatment goes up significantly. But at least in most of the recent studies that have looked at SBIRT for addiction, other than alcohol, it has not been found to be effective. So, you know, part of the challenge with treatment is that it only works if people take it. And so we have started to monitor the acceptance of clients of Vivitrol across all of our centers across the United States. And I know this is a very busy slide, but the reason I'm putting it up here is I just want people to get a feel for what it takes to monitor a system. That if you want to know if people are getting a long-acting opiate blocker to treat their addiction, you've got to have accurate data. You need to know how many people it was presented to, how many people agreed to accept it, and then whether or not they got the shot before they left. Because if they do not get the shot before they leave, they will not get that first shot. Period. So having a monitoring system that is system-wide, that allows you to know whether people are receiving treatment that's needed, is critical to success. So what's the future? You know, I think that the future is that, you know, detoxifications for opiates, when it's not paired with long-acting antagonists or agonists, is not going to be a standard of care that people can support. And that, you know, I think that we need to move away from this notion that abstinence-based treatment by itself can be the modal therapy. There are people, and you saw them on the slide, that are low risk, who in an abstinent and psychotherapy-based model are going to do well, but the majority of people with this disorder need medicine, and they need one kind of medicine or another. And the truth is that as much as we may prefer an antagonist like long-acting, you know, naltrexone or Vivitrol that blocks those receptors, that most of the good data that we have today has to do with buprenorphine or methadone. So if we were doing this based on published data and published evidence, we would always use those first. Treating depression and other co-occurring disorders becomes more and more important. Long-term outcomes are meaningfully influenced by treating co-occurring disorders. The problem is most substance abuse treatment settings are poorly equipped to do this, because it's not in the nature of drug and alcohol counseling programs to provide the skills necessary to do this. And finally, you know, agonist treatment, that is methadone and buprenorphine, will be seen through a medical lens rather than a spiritual lens. People aren't going to say, oh my God, they're not abstinent. They're going to say, thank God they're following medical recommendations and going to meetings and improving their lives. So that this notion that there's something about them that is inherently intoxicating will become much less important than getting to a year of stability. And finally, we shouldn't think that there's a panacea. Agonist therapies, whether it's buprenorphine or methadone, are not going to ever be sufficient by themselves. That if they're not paired with contingency management, individual counseling, support, we're not going to see any improvement in the overall success rates. So one final thought. I never thought I was going to be giving a lecture on how to treat with medicines about this, but I thought, Buckminster Fuller, who's a futurist and an inventor, once said, how often I found where I should be going only by setting out for somewhere else. Thank you.
Thank you. Any questions? Anybody have a question? Hold on. Oop. Wait, Paul.
Thanks. Hi again. My other question is that there's a lot of addiction to pain medicine, like you had alluded to, that's not heroin. They don't shoot it up, and it's real pain, and it's difficult to explain that they have to start taking less, but they still have the pain, whether it's back pain, accident, whatever. So what do you suggest to help that situation?
In our setting, we see a fair number of people being referred for abuse, if not dependency, on opioid pain medicines for chronic pain conditions. And because we work with certain in some of our centers, we see a lot of people who are working in safety-sensitive occupations. The federal government recently required a change so that supervisors could no longer be on things like benzodiazepines and narcotic analgesics. So we have a pain recovery program where we have lots of people with chronic pain who needed to come in because they wanted to stop their narcotics. And we have had a 0% failure rate in terms of treatment completion. That is, 100% of the people who come in have been able to stop their pain medicine. And the reason is that chronic pain medications do very little for chronic pain. So when people use chronic opioids, they get very little benefit. And there are really two reasons. One is tolerance, and we spent a lot of time talking about tolerance today. But the other is something called allodynia, or hypersensitization, where the pain centers actually become more sensitive to pain as a result of being on opioids. So perversely, not only do they do less and less because of tolerance, but then they actually make the pain worse. So we've had a great deal of success in just getting them off of it. Reducing it doesn't work. When we've tried to reduce the pain medicine, 2 weeks later they're back up on their dose. So, at least in our hands.
Hold on.
Your thoughts on the long-term use of Suboxone in the treatment of the opiate addiction?
So I think, it's always as compared to what? Most of my friends who became heroin addicted in high school or in college came off of heroin because they were on methadone. It's what got them off of the street. It's what got them into stable housing. And although none of them are on methadone 35, 40 years later, it was an important step in stabilizing them in the community. I think when we look at opiate dependency, the failure rates are very high. If you look at what the failure rate is on placebo, people who are getting placebo and support therapy have about a 10% retention at the end of a year, and that's across all studies. So success rates are very low for treating opioid dependency without medication. On medication for methadone, it goes up to almost 50%. On buprenorphine, it's about 40%. And on long-acting naltrexone or Vivitrol, it's about 30 to 35% at the end of the year. So I think the real question is who needs the medicine versus who doesn't. And I think if you use our scale as an example, there are certainly people who absolutely should be on Vivitrol or buprenorphine, and then there are people who may not need it. And if we're honest about them having previous treatment, previous overdoses, legal involvement, we would say all of those people need a medicine. And then it's really a question of what's the client's preference? What are they going to do well on? How do they feel about a monthly injection versus taking medicine every day? So I think at that point, what I believe is that what we owe our clients is to give them full disclosure and information about all the available treatments. We shouldn't be making decisions for them without informing them. We should be giving them the information and giving them appropriate guidance. And today there are many centers that do not do their jobs of informing people about what treatments are available. Many years ago, when I was at the NIH, there was a place called Chestnut Lodge that was a psychoanalytic psychiatric hospital. And it's really telling, and I think about this all the time. And Chestnut Lodge didn't believe in medications. This was in 1968, 1970. They believed that everybody could be treated with psychoanalysis. So if you were bipolar or schizophrenic or borderline, you were going to be treated with psychoanalysis. And not surprisingly, people stayed there a really long time. And there was one gentleman who was there for almost 2 years, spent the better part of 2 years in seclusion and restraints because he was bipolar, and they didn't believe in lithium. This is now in the early 1970s when lithium had already been approved. And so he sued the hospital, and they paid a huge settlement to settle the case. But I think there's really 2 points to this. One is he was never told. He was never given the opportunity to choose a different treatment other than the one they believed in. And I think the second thing is they were remiss because there were effective treatments they weren't offering. I'm not saying that I think every center has to offer every treatment, but I think every center has to educate their clients about which effective treatments are available and what their relative benefits and disadvantages are. If you're on buprenorphine, it's much harder to find sober living in the United States today than if you're not on it, that there are many homes and houses that won't take you if you're on buprenorphine. That's a consideration because it's going to affect where that person can live and what they can do afterwards. But it isn't the only consideration. There's also a hand up front, too.
Kaiser has done a study on childhood trauma called the Adverse Childhood Experiences Study. It's a massive study, 18,000 patients across the United States. And they found an extremely strong relationship between that trauma and addiction. And I was wondering, in any of these studies that you're quoting, is there any information on treatment of the trauma and how much trauma there was? Seems to be possibly related to the depression.
So very few studies of opiate dependency have looked at specific trauma treatment. That when they've looked at treatment, it's usually been a manualized therapy like, mindfulness-based relaxation or CBT or contingency management. So I don't know of any good published studies where they've looked at trauma, as a specific treatment focus. But it is true, women in particular who've been sexually abused, about 50% of the opiate-dependent women have had a severe trauma history, usually of sexual abuse. So this is a real issue for us. In terms of causation, it's less clear what to do about it from a treatment perspective. Yes?
Any thoughts on what could be done to reduce the availability of opiates?
Yeah, so I think that the best thing that has happened is now every state has a registry where a doctor can look up whether the person has gotten a prescription for opiates or benzodiazepines from other doctors. So the first step was to say, let's take physician ignorance and abuse out of the equation and make a more accountable system. And so in California, that system is the CURE system. If I saw somebody who was coming in for the treatment of pain, the first thing I would do is look them up on Cures and see who else is treating them and have them sign an agreement that no one else was going to give them these medicines so I could control it. And honestly, this is making a huge difference today. It's not going to change life for the people who are already addicted, but it should have a substantial impact on the people in the future.
One more here.
A comment and a question. Yesterday I watched a YouTube, it was called 7 Days of Heroin in Cincinnati, Ohio. And it was a documentary done on the opiate epidemic. And it was very interesting what the result was, where there were 180 overdoses reported and 20 deaths in 1 week time in Cincinnati, Ohio. And they're reporting that this epidemic is primarily in the Midwest, but spreading across the country. So I thought that was interesting, and I wanted to share that. 7 days of the heroin epidemic. My question is, I currently have 6 clients that I counsel individually who are on a implant implanted into their stomach for both opiates and alcohol. Mm-hmm. The implant is not FDA approved, However, they have paid out of pocket $10,000 for this 6-month implant, and they are required to get 15 sessions of counseling. I am curious what your thoughts are about that implant and
So the implant that they received is a naltrexone tablet. So it's long-acting naltrexone, but instead of having to get a shot every month, it's a slow-release tablet that breaks down and releases the naltrexone into the body slowly. Because it's not FDA approved, the manufacturers don't have to, naltrexone is, and in the United States, if a drug is approved, a compounding pharmacy can reformulate it as long as they're not violating a patent. So they can produce it. But unfortunately, one of the problems with the naltrexone tablets is that they haven't demonstrated stability over time. So we don't know if the person's getting the same amount of naltrexone in month 3 or 4 as they were in month 1. But if you assume that they are, then there are advantages and disadvantages compared to Vivitrol. The biggest problem with Vivitrol is that it only works for 30 days. If you don't show up for your second shot, you're at the same high risk of overdosing as you were a month before. So the implant solves that problem. There's also a long-term implantable form of buprenorphine that you can put in the shoulder, and that is FDA approved, and it lasts for 6 months. So that I believe that these longer treatments have a role. The big benefit for naltrexone, honestly, in addition to blocking opiates, is that it decreases cravings. And for reasons that we don't fully understand, naltrexone decreases cravings across drug categories. So it decreases cravings for alcohol, it decreases cravings for opiates, it decreases cravings for cocaine. So there's a very broad-based benefit that clients experience when they're on naltrexone. But I think that there isn't really good experimental data to support the implants at this point. The studies just haven't been done.
One more question.
I think there was one over here. Was it answered? Okay, so then there's one over here.
I have a comment question based on personal experience. If you go through a 9-month program and you're put on buprenorphine, nobody ever explains that the withdrawal from that is just as bad as it is from the opiates. And a lot of us are left hanging at the end of a year when you think you're supposed to go off of it, but all of a sudden all your treatment's done and there's no help available, and doctors aren't even informed of how to give you help. And some of us, I know personally, end up in rehab trying to get off the same medicine that you were put on in the very first rehab years ago.
Right.
Does that make sense?
So the question really is, what's the end game with buprenorphine, and how do you manage the withdrawal at the end? Yeah. And so part of the problem is that the buprenorphine studies weren't really done to answer the question of how long is long enough. So we don't know if 6 months is long enough or 1 year is long enough. What we do know is that in the short-term studies where people were on it for 6 months, a significant proportion of opioid addicts relapsed when they came off of buprenorphine. So in people who are doing well, I think there's a group of addictionologists who probably would say, what's the hurry? In other words, that it's not a year, so we don't know how long is long enough. The second issue is that you often see with buprenorphine is that it has other psychological and psychiatric benefits other than what you're taking it for. So that because opiates are powerful inhibitors of anxiety, people who have anxiety disorders often feel better on them than they do without them. And that's true for buprenorphine as well. And they have mood elevating effects, and that's true for buprenorphine as well. So some of what makes kicking buprenorphine difficult is because it may be masking or treating, depending on how you look at it, other psychological and psychiatric symptoms that will get worse when they stop it. The second issue is that there does seem to be a syndrome where when you get down to the really low doses of buprenorphine, you're cutting that film in half or quarters, that people start to have withdrawal symptoms. And in our experience, they can be managed, but a lot of times the doctors who are seeing them poo-poo it or minimize it. So again, I think it is a manageable problem. I just think that the skill level of the community in managing it is not that great at this point.
One more here.
Hi. I work at an integrated behavioral health program at a federally qualified health center, and we just recently received a grant from HRSA to do some expansion, specifically targeting support for this particular population. And I was curious, in a primary care setting, if you were to begin kind of a practice transformation for that medical team, where would you go first? Because a lot of what we've been encouraged to do for alcohol screening was the SBIRT model. So what would you do differently in terms of trying to kind of connect with patients that need potential follow-up or things that could be a
So it's
benefit?
not that SBIRT is a wrong place to start. It's that the benefits from SBIRT by itself are much more limited for opiates. So that I think that what we have to do is to say it's the referral part of the SBIRT that's important, and that it's really having an accountable system so that once someone is identified, you're systematically either providing that treatment or tracking them. And I think that, you know, again, the more steps there are, the more opportunity there is to lose people along the way. So that referral process, whether it's an internal or an external referral, is really where I would put my energy, is in how do we identify the people, how do we track whether they've gone, you know, what is our medication protocol for them?
Thank you, Dr. Sack. Great.
Oh,
Appreciate
thank you
it.
for inviting me, Mo.